I'm Dr. Rebecca Baskin, and I'm a breast surgeon here at Williamson Medical Center and Williamson Medical Group. So I was actually diagnosed at 36 with breast cancer. So at that time, I was a general surgeon, did a lot of breast surgery as well, and actually found a lump in the shower. My youngest was about 6 months old, and I'd stopped breastfeeding and gone back to work. And so I felt something in my breast, did not have a family history of breast cancer. And so then got my imaging. I was also younger than 40, so I'd never had a mammogram before. So that was my first episode of having mammogram and ultrasound. And there was a suspicious looking mass on my imaging. So very quickly had a core biopsy. And then I actually worked with one of my peers who was one of my partners and made decisions about what surgery I wanted and kind of moved forward from there. Back then, there was kind of two buckets that you were in. You were either no positive or no negative and needed chemo or didn't need chemo. It was a lot more straightforward. Things have changed a lot since then, but I did need chemotherapy. So I had surgery and chemotherapy. With the surgeries that I chose, I did not have radiation therapy. So I was a general surgeon, and in general surgery, we do a lot of breast health work. So seeing women with benign breast issues as well as cancers. So as a female surgeon, I already did about 60 to 70% of my work was breast already, but I also did thyroids and colons and things like that. When I came back, it really opened my eyes being on the patient side of things. So I'd always enjoyed the variety of what I did, but I felt when I came back that I really needed to focus, and things were changing so quickly in a lot of different fields, but especially in breast. And so over time, talking with my family and, talking with my partners, I eventually transitioned over and specialized in breast. So that now I'm 100% breast cancer and breast health surgery. I've actually been out now 20 years, so there've actually been a lot of changes for breast. So when I first started, we were doing core biopsies for mammographic findings. And then early in my career, we were learning and doing extra education and learning how to do ultrasound guided core biopsies. And as a surgeon, originally we were doing those. Now radiologists as well as surgeons do biopsies. We're doing a lot more diagnosis up front, not in the operating room, but with cores. And so that's really the preference, because I think it's always a good idea. And our guidelines say that it's best to know what the diagnosis is as best you can before you start doing surgery. I think one of the things that has changed is there are a lot of cancers now that are actually treated by an oncologist with chemotherapy before we do surgery. So that percentage has changed a lot, because as we improve and do more and more studies, we realize some of these women, if we can do their treatment before surgery and realize that we've shrunk the tumor to nothing, they now can not have to have as much chemotherapy or additional chemotherapy. So the recommendations have changed on sizes and types of cancers for that. I think since I've been doing this over 20 years, obviously the addition of MRI has changed things a lot, and trying to get planning for cancer surgery, trying to determine better how big that cancer might be, and to make sure there's not another cancer in that breast or the opposite breast before the woman makes her decision for surgery. We still do. When I say a woman, I don't mean to discriminate. We do have a few men, obviously, that have breast cancer. It's much less common. But we do take care of both men and women, and are obviously proponents for screening as well. I think the value and just the accuracy of mammograms have greatly increased over time. The technology has changed. Some of the new changes with that is something called 3D tomosynthesis. So women that have really dense breast tissue can ask for a 3D tomosynthesis, and it gets a better picture of their breast. I tell women it's kind of like having action shots of your breast. When you're in that compression, the camera actually moves and takes different pictures. And the computer can reconstruct the breast in a 3D model so that the radiologist can scroll through that imaging. So instead of just looking at two flat pictures of your breast, they now can scroll through the tissue a lot more like an MRI or CT. And so we're finding things smaller and earlier, especially in women with dense breast tissue, that we might not find for a while with just 2D imaging. I think one of the most impactful is when we see women back that have had very advanced disease and they're still survivors and thrivers with us. So I have some very young patients. The longer I've been working, the more variety you have. And I've had several young patients that are doing very, very well. They're disease free and surviving and thriving. And 20 years ago, we might not have had that same outcome. So to see the changes in surgery, to see the changes in reconstruction options and in cosmetic results for these women that I believe have improved over time as well. The fact that technology has changed and we're finding them smaller and earlier. And then the medical oncology and radiation oncology side of things, that we've got better treatments to protect the whole patient and to protect the breast, that I think we're seeing longevity that we had not seen before. So we're seeing these women live very long and happy lives after it, even when they have advanced or more aggressive cancers. And so I think sometimes that's always beneficial to me to have those ladies come back and see them and remind myself that we do this for a reason, and that we're doing this not just for what's going on with that patient this year, but 5 years from now, 10, 15, and 20. And to get to see those women so far out and having a great life, that's when it really comes back to us. I think it's always good for us to remember we get sometimes so focused on the treatment process, the surgeries, chemotherapy or endocrine therapy and radiation. They're all very important, but also our quality of life after those things are over. So how we're living with our diagnosis afterwards. And so Pretty in Pink has always been so helpful in women. They do the measurements for the lymphedema sleeves and gloves. They're also helping us pre-operatively, getting women fitted for post-operative bras. Even for women that are having lumpectomies, so that it helps them be comfortable and decrease, some delayed bruising and bleeding and keeps them more comfortable. I think also they're there for us as for women that choose mastectomy with no reconstruction, measuring those bras, getting them in the right prosthesis. And I think it's just another level of care that I think is very important to women on a daily basis. These are things that affect their life every day. So making sure that we have that aftercare, one of the words that we use is that we're making sure we're still taking care of that woman after the immediacy, because all the days that come after it are important too. I think obviously attitude is always important, but I also think that remembering and kind of that your journey is yours, and to not get overwhelmed by everyone else and all your friends and family making recommendations. It's good to hear those things, but remember that your journey is yours and that every woman's journey is different. So I see many cancer patients every month, and our recommendations differ from patient to patient, and their journey is going to differ. So just to keep a positive attitude and remember that we're with them through this whole thing. I think we definitely oftentimes want to get things done so quickly, but to realize that in a lot of times this is a journey, and we just take every little step at a time and get past that hump and celebrate that victory before we go to the next one. I think always this is a good time to talk about screening, and just to let women kind of remind them of some of our recommendations. I know there was some confusion a few years ago about the task force, and you don't have to start mammograms as early or do them as often. I'd like to let most people know that that is what was called general population. So for women that have never had biopsies, they don't have dense breast tissue and don't have any family members that have had breast cancer. That's a very small percentage of women. So we still all feel in gynecology, radiology, and breast surgery, general surgery, to start screening mammograms yearly at age 40 and to continue until you have at least, maybe you don't have 10 years of longevity left, and that is not a number. So there's no set age to stop mammograms. It's more based on the woman's health and how healthy she is and how long that she and her doctor feel that she has left to live. And we still want to be screening. Because we're catching things earlier and smaller. The smaller and the earlier we catch them, the less treatment that's actually required in the long run. I think also with 3D tomosynthesis, we're having fewer callbacks, and we also have many of the facilities, just like Williamson's Breast Center, is we have the smart curve paddle. So it's a more ergonomic paddle that gets better even distribution. And so we think it's more comfortable, and many patients say it is more comfortable to have that compression. So we don't want women to be scared about getting screening. We want them to get their screening and not wait too long. The other thing that we talk about is if there is a family history of young breast cancers, that 40 may be too late to start screening for those women, that you want to start screening 10 years younger than your youngest relative when she was diagnosed with breast cancer. So we'll make sure we capture those women, and you can always have that conversation with your primary care doctor and your gynecologist to see what is your risk and when is it a good idea to start screening.